Meta-selfcare in chronic conditions, the evolution of patient expertise. And this is really my pleasure to introduce my friend, Laura Rigere, researcher at PATH, Participatory eHealth and Health Data Research Group, and Deputy Director of the Center for Disability Research at Uppsala University. Sara, the floor is yours. Please help me in welcoming her.
Thank you so much. This is actually the first time this work is presented publicly anyway, so this is the first conference we're at. And I'm here to present this work on behalf of my collaborators Therese Scott-Duncan, Dawn Richards, and myself. This is this research is part of a 4-year research project called Chronic Knowledge. It's funded by the Swedish Research Council. And in the project, we will be establishing, describing, and exploring the concept of meta-self-care in chronic and long-term conditions, diagnosis, diseases. So it's pretty broad. And the team of our project consists of my colleagues at Uppsala University and our Canadian collaborator, Dawn. And we are supported and eagerly watched by our international panel of chronic knowledge experts, which is very international indeed. This project takes its starting point from my own experiences from living with Parkinson's disease for over 40 years. I see my neurologist approximately 1 hour per year, symbolized by the one red dot in this image. The rest of the year is 8,765 hours. I spend in self-care, where I take care of myself in the best way I can. And it is during that one red dot in healthcare that my neurologist prescribes my medications for the rest of the year. But it's in all those hours of self-care, all the blue dots, that I put that prescription into action. Because in fact, my neurologist doesn't even know if I take my medications or not. But I do, of course, because if I didn't, I wouldn't be here. I wouldn't be able to take care of myself, I wouldn't be able to work. And I certainly wouldn't be able to be here to present to all of you. So what do people living with chronic conditions need to live a good life? Not only during that one red dot of the year, but also during all the 8,765 blue ones. We need knowledge. And here I have called it patient knowledge. That's not a coincidence. This is different from clinical knowledge. It's a patient knowledge. It's essential for living a good life with chronic conditions. It's not instead of clinical knowledge, it's complementary to the clinical knowledge, in addition to. And there isn't a lot of published research around patient knowledge. This is one of the very few exceptions. This is a great paper published in 2024, where they examine and classify patient knowledge by source of learning. And they go beyond experiential knowledge, and they talk about it as experiential, relational, information-based, among others. This work gives us, in our project, a conceptual vocabulary for something that has been very largely invisible in healthcare literature. And this framework, we build on this framework, among others, for digging deeper into the epistemological question of why patient knowledge has been systematically undervalued. And that's the gap we're trying to close and address in this project. Because if we follow the evidence, we can find that patients who are engaged, knowledgeable, and proactive have better outcomes, cost less, and live longer. So the case for investing in patient knowledge is not only ethical, it's also economic and clinical. And despite this evidence, we lack a solid research foundation for understanding how that knowledge develops. When we talk about the problems in healthcare, there are a few issues that are always mentioned. Chronic conditions are increasing, healthcare systems are struggling, and much more seldom, but my personal favorite is that the research on self-care is lacking. But are these really core issues? Are these really the underlying core problems? Or are they symptoms with a common cause? Chronic conditions are increasing, yes, that is very true. But it's largely a consequence of our scientific progress. And it's actually a success to be celebrated, because instead of dying from conditions that we wouldn't have died from maybe 10 or 20 years ago, we can survive with lifelong treatment and different kind of interventions. So I think we should celebrate it rather than say it's a problem. Healthcare systems are struggling, but it's not a new insight. We have known for over 50 years that the models used in healthcare are better suited for acute and long-term conditions. So we have known that for over 50 years. So why haven't we changed it before? And third, yes, research on self-care is lacking. But why? I would argue that it is because we have not yet recognized self-care as a knowledge domain that deserves systematic study. The systems that fund and evaluate research are built around the same epistemic assumptions that make patient knowledge invisible. And to understand this further, I went back to Aristotle. Aristotle talked about three different kinds of knowledge: episteme, which is theoretical, universal, verifiable knowledge; techne, which is craft knowledge; and phronesis, which can be described as practical wisdom. Episteme is the dominant form of knowledge in healthcare. It's about clinical guidelines, randomized trials, and biomedical evidence. Techne is the practical skill of competently executing a task. And here's where conventional self-care largely lives. It's about teaching patients how to administer insulin, how to maybe take their blood pressure or follow a dietary plan. Phronesis is the capacity for good judgment in complex real-world situations. This is developed through lived experience and reflection over time. This is the form of knowledge that people with chronic conditions develop, often across decades. And it can only belong to the person who has cultivated it. It cannot be delegated or extracted. And it has been almost entirely invisible in healthcare. So here is what I would argue is the core problem. The knowledge system in healthcare is organized around episteme, universal, verifiable, context-independent knowledge. Patient knowledge, particularly of the phronesis kind that is developed through years and years of living with conditions, is not recognized as valid within the system. Whose knowledge is used as basis for decisions? And who decides whose knowledge is being used? This is not just an oversight, it's a structural feature of how healthcare is organized. And it is a form of epistemic injustice, meaning systematically undervaluing someone's knowledge based on who they are. So the question then becomes, how can we change this? And this is what we want to explore in the Chronic Knowledge project. Before introducing our proposed concept, I want to take you on a bit of a historic excursion. The concept of self-care started being formalized in the 1950s and 60s. And Dorothea Oram's nursing model gave it clinical grounding in the 1970s. Although that was largely nurse-centric. There was self-management coming out as well in childhood asthma, in behavioral psychology. The Alma Ata declaration brought self-care into primary healthcare, so they used self-care as well. So different terms have been used over time. And then Kate Loring, for decades, developed self-management programs for chronic disease. And then recently there was use of self-care as a term again for chronic disease specifically. And these are all very valuable frameworks, but they share a common mistake or oversight. They position the patient as someone who executes a plan designed by healthcare. The focus in these frameworks is on technique and adherence, not on the development of independent knowledge, judgment, or the kind of practical wisdom that Aristotle called phronesis. This is why we want to propose the concept of meta-selfcare. While conventional self-care or self-management is a process for maintaining and improving health and well-being, meta-self-care operates on a different level. It's a process by which people develop the knowledge, skills, and understanding needed to live what they themselves define as a good life, in the presence of illness or disability. The meta is deliberate. It describes knowledge about and for self-care, not just self-care as execution. The goal is not adherence to a plan designed by someone else. It's the development of epistemic agency. The capacity to form, test, revise, and act on one's own understanding of one's condition and what matters in living with it. This definition, the definition of a good life belongs to the person living it, not to the healthcare system, the clinical guideline, or the clinician. So, why does this matter? Well, we cannot improve what we cannot describe. So giving this process a name creates the possibility of studying it, measuring it, and supporting it. This is a way of starting to correct epistemic injustice. And when patient knowledge is treated as if it doesn't exist, people are harmed, not just practically, but also epistemologically. And recognizing meta-selfcare as a legitimate knowledge domain begins to correct that, and we are convinced that change is possible. The Chronic Knowledge Project runs until 2029, and this link will take you to a place where you can sign up to get updates from the project. We are very much in the early phases of building this framework, so if you are interested in following us, do scan the link and contact me if you want to talk about something or suggest something or ask questions. Thank you for listening.